Welcome everyone to the 12th installment of our Clinical Best Practices in the World Trade Center Health Program, the webinar series. So today's talk is going to be on gastroesophageal reflux disease, or GERD, and it will be presented by our two colleagues from Rutgers. So Dr. Udasin, who is Professor of Environmental and Occupational Medicine, and also Medical Director of the Rutgers Environmental and Occupational Health Services Institute Clinical Center. And she'll be accompanied by Dr. Ruth A, who is a staff physician also at the Rutgers Environmental and Occupational Health Services Institute Clinical Center. And I should introduce myself. I am Dr. Jeff Calvert, and I'm with the World Trade Center Health Program, which is part of NIOSH and CDC, and also helping me out with all the technical aspects of this webinar are Kiana Harper and Ann Riddle. We have a few disclaimers. So one is the views expressed in this presentation are those of the speakers and don't necessarily represent the official position of NIOSH or CDC. Two, mention of any trade names, commercial practices, or organizations does not imply NIOSH CDC endorsement. And finally, citations to websites external to CDC NIOSH do not constitute their endorsement, and CDC NIOSH is not responsible for the content of those external websites. And we do have one disclosure from one of our planning committee members, Dr. Delahose, who attended some promotional programs by pharmaceutical companies. Those relationships have been mitigated. Next slide. So as I mentioned, today's talk is going to be on GERD, and the source material for this presentation is from a paper that was published in the Archives of Environmental and Occupational Health. And so the screenshot of that paper is on this slide. You can see Dr. Lin is the lead author, and Dr. Udasin and myself are co-authors. And so this paper is available free access on the internet. And now, without further ado, I pass the microphone to my colleague, Dr. Udasin.
So thank you everyone for coming. It's lunchtime and I hope you're all enjoying a nice healthy lunch and avoiding your own personal GERD triggers. So I want to point out that we're all a bunch of internists. We're not specialists, subspecialists, but I think it's relevant because this is how we see people in the clinic, and we want to help you as much as we can. So next slide. So since we're speaking about reflux, of course, we have this very British slide here that we use. But what I want you to notice here is the endoscope, the esophagus, the stomach, the duodenum, the lungs. So when we talk about symptoms and chest pain, you can see which body parts that we're referring to. So next slide. So this is a really good definition slide here of gastroesophageal reflux. So it's reflux above the lower esophageal sphincter. Protective lining in the stomach to the less protected esophagus and airway linings. And you can see that the stomach is in a good place and the esophagus maybe not so much. Objectively defined by a characteristic mucosal injury seen on biopsy when endoscopy happens, and were abnormalities on a reflux monitoring study. So next slide. So when we first did this slide, GERD was the second most common World Trade Center certified condition, and now cancer is higher than GERD in terms of certification. So sinus being the highest, and cancer being the second highest, and GERD being the third highest. Statistically, risk factors for GERD are early arrival at the World Trade Center sites, like every other World Trade Center condition, exposure to dust, comorbid asthma and respiratory disease, but overwhelmingly there is clearly an interaction between how people dealt with psychological stress associated with the terrorist attack and post-traumatic stress disorder. So Moving on, so next slide. So why is our GERD different from all other GERD? And our GERD is different from all other GERD that people get, not in World Trade, because we don't, outside of World Trade, have so many comorbid things associated with GERD. Most of us who get GERD have life problems, boss problems, family problems, alcohol problems, whatever we have. But most people outside of World Trade don't have all the asthma and sinusitis that our World Trade Center patients have. Next slide. So these are the common GERD symptoms. Heartburn and dyspepsia are the more obvious ones that someone's having reflux, particularly if they can associate it with food. Some of the less obvious ones are sore throat, difficulty swallowing, cough, chest pain, hoarseness, laryngitis. So some of those symptoms are easy to diagnose GERD and some not so much. Next slide. So assuming that people have some of these symptoms, people have GERD, but when do we worry about a symptom and when do we perhaps want to look at other things going on in addition to usual GERD symptoms? And these are things people can get with GERD. Chest pain. So you can get your chest pain from GERD. Remember back to the beautiful anatomy slide I had with the esophagus beginning with O. Chest pain when there's no relation to food suggests obviously we need to look at cardiac problems. Dysphagia, when a patient complains about not being able to swallow liquids, you can't swallow solids, it's less of an alarm, but when you can't swallow lipids, then we start worrying about some of these other things. And of course, some of these are more worrisome than others, but when you really have a patient with dysphagia, while we go through a workup for GERD, we are going to have in the back of our mind all of these things, but especially esophageal cancer. Globus. I don't think I ever saw much of this until I was involved with the World Trade Center program, but we have a number of patients that present with the sensation of the lump in the throat or even odynophagia, painful swallowing. And we do want to think about other conditions, particularly immune conditions, thrush, things like that. So those are things we think about. Next slide. I was trying to figure out how to make this into 2 slides and I couldn't, but in terms of other things that could be going on besides GERD, within the esophagus, I mentioned the worrisome ones. Non-reflux esophagitis, surprisingly seen more commonly than I would have thought. Pill-induced while you have a swallowing problem. Unfortunately, we have many of our patients that have radiation-induced swallowing problems because they were radiated either for their lung cancer or some other cancer that needed chest radiation. And that's very real that we have non-reflux esophagitis in those patients. So that's important. Some of the others are anatomic situations, the strictures and diverticulum that are a little more exotic. Other things to be considered, peptic ulcer disease. Peptic ulcer disease can occur with GERD, it can occur without GERD, but if you suspect peptic ulcer disease, it's certainly a good reason for doing an endoscopy. Gastritis is something that many of our patients have. Gastroparesis, people have that for reasons that you have another systemic illness that causes that, but it's something to be mindful of. Hiatal hernia, this always comes up. How important is the hiatal hernia? Should the hiatal hernia be fixed? Should it not be fixed? And we can think about that later when we speak about our cases, but this comes up in a lot of clinical situations. And of course, the non-GI disorders. So I said coronary artery disease is the most important and most common of these issues, but we certainly have patients with diseases of the larynx and pharynx and pulmonary problems. So next slide. So in our usual patients, if you see them outside of the World Trade Clinic, most primary care doctors start off with an 8-week trial of a proton pump inhibitor and see how the patient does. Proton pump inhibitors, of course, most commonly omeprazole, see how they do. After they finish the trial, in some cases, it may be appropriate to do an endoscopy 2 to 4 weeks after stopping the proton pump inhibitor, particularly if they have symptoms. In patients where the endoscopy is not clear, pH monitoring might be indicated. Objective testing and pH monitoring is certainly recommended in patients when there's chest pain and the cardiac cause is ruled out. So of course, when we have the need to do endoscopy and pH monitoring, this is clearly the need of the specialist and not something we as primary care internists do. I include the barium swallow as a negative here because barium swallows, they used to do them all the time, and they're really not indicated for things associated with GERD. They are used in some more complex cases, but certainly not in the diagnosis of routine GERD. Next slide. So here is our proton pump inhibitor test, the PPI given, as I said, usually from 4 to 8 weeks. So you can see it's not all that sensitive, and it's even less specific than it is sensitive. So this kind of makes it hard for us to know, is this the correct diagnosis? Because clearly there's a lot of people we miss with this. There's a lot of false negatives, but there's even more false positives. Feels good to be on a proton pump inhibitor for a lot of other reasons. So do they really have GERD? Do they not really have GERD? And look at this statistic we were able to find. Somewhere between 38 and 90% of patients have improvement in their symptoms. So clearly people may have improvement in their symptoms. That's really a statistic that's of limited usefulness, or you could say it's useful because you don't know if the proton pump inhibitor was doing what it's supposed to do. But I include that for everybody's thought processes. If they're having extraesophageal symptoms, meaning not just the heartburn, maybe they're having throat issues, maybe they're having some chest pain or whatever, you might want to consider lengthening the trial to see if it does any good, and that you might want to do that. So including that for your review. Next slide. Indications for the upper endoscopy in suspected or known GERD. Okay, clearly typical GERD symptoms that persist after a PPI trial. Clearly they have the alarm symptoms. Anybody that has dysphagia for sure, anybody that has weight loss, you're doing the endoscopy, you may or may not even be doing the endoscopy thinking about GERD. You're doing the endoscopy thinking that hopefully they're going to pass the endoscope and there isn't going to be some kind of an obstructing cancer when you see those. So those are clearly get that endoscope into that patient as soon as possible. Atypical symptoms and to exclude other upper GI illness. And these are some of the things we see. If a person has had a past history, if you're concerned about Barrett's esophagus, they certainly need an endoscopy. They need it for treatment of esophageal stricture. This is the World Trade Program. I tend to err on thinking about Barrett's esophagus in our patients, and indeed, most gastroenterology societies recommend screening for Barrett's in male patients older than the age of 50 with chronic GERD and additional risk factor. So that's almost all of our patients. Men older than the age of 50 with chronic GERD and additional risk factors. I wasn't able to find an equal statistic like that for women. That's as consistent as the male statistic. So basically, in world trade, I think that erring on the side of doing endoscopy is the appropriate thing because we don't want to miss any Barrett's esophagus. Next slide. So complications of GERD, stricture, ulcer, Barrett's, and esophageal cancer. So that's why we don't just dismiss GERD and say, oh, it's not a big deal, because some of these things are pretty important. Next slide. Another thing to consider with GERD symptoms is to make sure you've looked for Helicobacter pylori, because this can cause our patients a lot of distress, and the treatment is not exactly the same as the treatment, but we can make people feel better. Notice the dates on our references. They're old. I'd like to think this is decreasing worldwide with improved water sanitation, because how do you get the bacteria in you? The bacteria comes from water, but nonetheless, this condition still persists. The bacteria penetrates the mucous membrane of the stomach, establishing infections. So why is that important in world trade patients? Because we already have so much mucous membrane irritation of everything because of all the dust exposure. What's important about H. pylori is it's one of the only known bacteria known to cause cancer, and it is a causal agent in gastric ulcers as well. Some statistics said it over half the world population infected, but most asymptomatic. That's probably less true because these classic references are old, but it's still significant. So it is recommended in all patients that are age 60 or younger with dyspepsia, and that it's recommended to be tested for it. Tested for it if they're younger is not necessarily with endoscopy. It could be with breath testing. Patients older than 60 should definitely have endoscopy. And again, treatment is indicated to prevent gastric cancer. So next slide. Next slide. So how is H. pylori treated? So this is a change, and this was, you could see we have a more recent reference for this. This is a change in how H. pylori used to be treated. The old regimen was the triple regimen, including clarithromycin, and it's still the most common in the world, but now there's a quadruple therapy, using the PPI, bismuth, tetracycline, and metronidazole. And so this is a new treatment regimen, and this is where we're going then with treatment for H. pylori. And we will also advise that patients that have been treated for H. pylori after treatment undergo another test for H. pylori, but the next test for H. pylori is not another endoscopy. It would be the rebreather or fecal antigen test. Next slide, which is about Barrett's. So why do we care about Barrett's? Well, we said that it can turn into cancer. Somewhere between 3 and 12% of patients with chronic GERD have Barrett's. And again, it's a main risk factor for developing esophageal endocarcinoma. Annual risk of esophageal cancer in Barrett's without dysplasia is 0.12%. However, with dysplasia, it is certainly higher. Initial screening, particularly, we said that symptomatic patients 50 and over, if negative. Okay, this is really important. This is really important here. If you don't have Barrett's and you're over 50, they don't need to keep doing endoscopies and you're looking for Barrett's. We now know we have good medical evidence that if you don't have Barrett's by the age of 50, you're not going to have it and you don't need to keep having a million endoscopes. You might need another endoscopy for symptoms, looking for other reasons, but you don't need it with the specific reason that you're looking for Barrett's. If you're dysplastic, clearly an immediate ablation is recommended. And for Barrett's without dysplasia, screening is recommended every 3 to 5 years, depending upon the length of the affected esophagus. And I usually let the specialist tell me what the official time when they need to have the next screening done. But for those of us that are not the specialists, when we get those reports back, we should be looking in the report for how much of the esophagus is exactly affected versus how much is not affected. So this goes to the next slide, which is our poll question here. Okay, so I guess I can read the question. Treatment for GERD includes which of the following, and you guys should suggest the best answer. A is weight reduction if the patient is overweight or obese. B, elevating the head of the bed at night by 6 to 8 inches. C, avoiding meals within 2 to 3 hours before bedtime. D, use of proton pump inhibitors. And E, all of the above. Now it says we're not allowed to vote, so Jeff, we can't vote, right?
You and I can't vote, but the audience can vote.
Okay, so we wait for answers now?
I think, yeah.
Good. Okay, so everybody got the right answer that the answer is indeed all of the above. We're going to be telling you next slide, I guess. Next slide here. Okay. I don't know if you guys saw the answers before you looked at it, but we spent a lot of time talking about overweight and obesity, and we have some slides in our treatment about that. Elevating the head of the bed, avoiding meals. It's not so easy to get people to avoid eating big meals, but it is something that we spend a lot of time thinking about. And of course, the proton pump inhibitors, where would we be without them? And they are more effective than the H2 inhibitors. So next slide about treatment. Okay, so diet and lifestyle have a bunch of slides that are going to be coming up, and we'll go through them. The pharmacologic and the surgery. This is what I'm going to be going through, and then I will shortly hand off to Dr. Lynn after I go through these slides. So next slide. Being attentive to other medications that cause or exacerbate GERD. So the medications that exacerbate GERD by decreasing the lower esophageal sphincter pressure or slowing gastric emptying include opioids, which many of our patients are taking because of their musculoskeletal problems, calcium channel blockers for their blood pressure, nitrates for their hearts, anticholinergics and alpha agonists for a lot of reasons, and phosphodiesterase inhibitors and sedatives, and of course, aspirin and NSAIDs that they're also taking for their aches and pains, bisphosphonates for osteoporosis, probably not that many people at this point, and we'll go to the next slide. non-pharmacologic treatments, diet, lifestyle, and behavior modification. So let's go to the next slide here. So the idea that non-pharmacologic treatments can be helpful is accepted. However, there aren't a lot of studies that really prove that they work. So we'll go to the next slide, but we should all be doing this. Weight loss, we routinely offer our patients with reflux the nutritionist, and if they want to see the nutritionist, that may help. If they want to go on other kinds of diet, because clearly weight loss helps, raising the bed 6 to 8 inches. Sleeping on your side is certainly better for both GERD and reflux. If you can get to that left lateral decubitus position, that's a great position to be in, because you will lower the pressures and you will improve your GERD situation. I spend a lot of time talking to people again about not eating too close to eating before bedtime, or even what you can eat before bedtime, because people who don't eat certain foods, if you feel the need to have something low fat, like fruit, is probably okay. Next slide. Tobacco is a good one. So the question here about alcohol always comes up, how important it is to avoid alcohol or not, because while there isn't as much direct effect about avoiding alcohol, certainly alcohol promotes weight gain. In many people, alcohol can be a trigger. So while we don't include it here, I kind of lump it into the avoiding high-calorie food and beverages. Knowing your food triggers, so avoiding really large meals. I talk to patients about sitting down when they eat and eating slowly, because sometimes, and I may be extremely hungry after doing this talk, sometimes when you're extremely hungry, you tend to eat too fast, and that's avoiding doing that. Cognitive behavioral therapy may help, and breathing in, that may help. So next slide here. And again, we mentioned all these things, the mechanism with obesity, tobacco, and alcohol. I like to tell my patients, this is my New York and New Jersey thing, I like to tell my patients that are overweight and they drink too much, that they're only allowed to eat big meals and drink alcohol when the Giants and the Jets win, which is a really good way to get people to lose weight and stop drinking, because they never win here in New Jersey. Next slide. Changing in sleeping habits. So we said a lot of these things already, but practicing good sleep hygiene is important. Next slide. Behavioral treatment, if you can do it. Some of our therapists do this. Cognitive behavioral therapy is well established, treats a lot of different things for our World Trade patients. Next slide, which is extremely busy and annoying, but basically includes all the things people do to treat GERD, and you can see the antacids are here, mucosal protectant sucralfate is here. We don't really have to worry too much about pregnancy. The H2 antagonists are here, the proton pump inhibitors are here, and some other motility agents are here as well. Next slide. So how do we select our treatment? Pretty much no difference in effectiveness of any of the H2 inhibitors, and no concern about side effects. So what does that mean? That means you don't have to worry about, do they have heart disease? Do they have this? Do they have that? You can always give them the famotidine or whatever, or the H2 inhibitor of your choice, without worrying about the side effects. Of course, it doesn't actually work as well as the other medications. There's some variability in effectiveness of the PPIs. There are some studies that say that perhaps the esomeprazole is more effective than the others. So we use that sometimes. Dexlansoprazole or Dexalent, it's a dual delayed release. It has fewer restrictions. It may last longer. It's more expensive. It's not a first-line agent for that reason, but it is a good drug and should be considered. Some people feel like the omeprazole with bicarb is good. We have very few pregnant patients in our World Trade Center program, but I stuck that slide on for you to have that reference, avoiding calcium and magnesium containing antacids. Next slide. So how long should the patients continue the PPI? If there's erosive gastritis and Barrett's, you want to continue it because you're worried about the long-term effects like cancer. But if you do not have those issues, you do want to try and decrease the effects, decrease the length of time you're taking that. Side effects of PPI in the next slide. There's all these studies. I can't take my PPI because this, that, or the other reason. And I want you to know that there were no high quality studies that really demonstrate any of these problems. Having said that, I would be consulting the cardiologist and the nephrologist about patients that need to be on PPIs. And we just published something, a World Trade Center study showing that there's no evidence that the PPIs cause MI or stroke. So let's go to the next slide. So what do you do if the PPI doesn't work? If the PPI doesn't work, you are going to need the specialist. You are going to be thinking about ambulatory reflux monitoring, possibly using telemetry, high resolution manometry. Barium radiography is not recommended unless the specialist has some reason for it, but it's not generally recommended. My last couple of slides, surgical therapy, next slide. You've got objective evidence of erosive esophagitis, hiatal hernia, comma doesn't belong, abnormal reflux testing. Traditional surgery includes the Nissen fundoplication. That's the major procedure that's historically been shown to give some relief. Surgery often includes repair of the hiatal hernia. No evidence that surgery prevents esophageal cancer. Surgery should only be done for relief of symptoms. I have a few miserable patients that had surgery, and they're not such miserable people. They used to be miserable people, and they had their procedures. And my last slide is the next slide. So now the more invasive surgical procedure, we now have a non-invasive procedure, the TIF procedure, and we have specific endoscopists that can do this. This is a transoral incisionless fundoplication. So the tissue valve is created. The current recommendation from GI societies is if a person's considered an appropriate candidate for the TIF, that you should do the TIF because it does work and it's far less invasive than the other procedure. And now I'm turning it over to Dr. Ruth Lynn to discuss some of our very interesting patients in this population.
Hello. Okay, so patient one is a law enforcement responder. He came to our program at age 35 in 2007. He had severe symptoms, rhinosinusitis, GERD, asthma, and anxiety. Started about 2004. He was on famotidine daily. For the GERD, seemed to help. But he also had, a severe sinus symptoms. So he had sinus surgery, which helped to decrease his symptoms and number of sinus infections. He also went to pulmonary and, was added on medications, the inhalers, which seemed to help. And for his anxiety, he went to see the mental health provider and medications were prescribed for him. And then the next visit was about 2 years. His GERD at that time worsened. He changed his medication to the PPI to esomeprazole, and it was an increase in dosage, even up to twice a day as needed. It helped initially, but then worsened again. So he had endoscopy, which showed H. pylori, no Barrett's esophagus, and he was treated. At that time, the course is a triple therapy, so that was lansoprazole, amoxicillin, and clarithromycin. And then, asking him further, he recalled that he had been treated before for it with triple therapy. Then when he completed that, he changed the PPI to dexlansoprazole. But his GERD symptoms were still severe. Next slide. So this is a poll question. So what we would recommend for him at this time? And the choices are A, repeat the medication treatment for H. pylori. B, change the PPI therapy and add a H2 blocker. C, refer to infectious disease specialist. D, refer to the surgeon. It would take a few moments. Okay, so let's see. Okay, the highest number would be to change the PPI and add to the H2 blocker. Yes, we think, right, in other responses, there's a tie between treatment for the H. pylori again, or refer to surgeon. We actually, think that C, was a better option. Okay, I could go through the choices. A, for the repeat treatment for the H. pylori, there's antibiotic resistance increasing. So that, we thought it would not be so helpful at this time. Up to even 33% with clarithromycin or levofloxacin regimens having resistance. B, this choice change the PPI therapy and add the H2 blocker. We can do that, but it doesn't address the H. pylori treatment. C, we thought, is a better choice and is the answer, and which is what we did for him. He had multiple courses of antibiotic therapy to treat the H. pylori, and the risk of potential resistance. And of note, right, for sinus infections, he also had antibiotic course. So we actually referred him to infectious disease specialist to help guide the therapy. And then D, the choice we didn't think was a good option either. So there was no indication for surgical evaluation at this time. He received at that time with the other triple therapies, Levaquin, amoxicillin, and esomeprazole. Next slide. Okay, so our next patient presentation is here. So he came in 2006 at age 50, worked in construction. He had severe GERD symptoms, rhinosinusitis, and asthma since 2002. And he was on omeprazole and, would occasionally take the calcium carbonate or Tums. He had endoscopy, which showed gastritis, esophagitis, no Barrett's esophagus, fortunately, no H. pylori. He also had a small hiatal hernia and, was changed to esomeprazole. He also was referred to the ENT, which showed reflux laryngitis, so recommended to continue the PPI therapy, as well as, nasal treatments. And the asthma was on albuterol as needed. Okay. And then next year when he came, work was a little unstable. He was in between jobs and was depressed. So we referred him to the mental health therapist, as well continued, with GERD symptoms. So he was on the PPI. And then the following year, he came in with multiple infections, nasal, pulmonary bronchitis. So, he went to the pulmonologist, the ENT. As well, he went to the GI doctor again and with the symptoms and was changed to a different PPI, to the pantoprazole. Next slide. And then the following year, 2009, it was, a stressful time again. He had a new job. He was continuing to see the therapist. And, with a busy life, he missed the endoscopy, which some of our patients do. And the following year, 2010, he had a lot of sleep apnea symptoms. So he went to get the sleep study and was ultimately diagnosed with severe sleep apnea and treated with a CPAP. The GERD symptoms continued. He went to the private GI doctor again, had endoscopy, showed this time now he had Barrett's esophagus without dysplasia, and the esomeprazole was increased, 40 milligrams twice a day. Okay. And the following year, he went to see with the GERD symptoms. So he went to see the World Trade Center GI through the referral. Was recommended, to change back to the pantoprazole twice a day, but he was still symptomatic. The following year, right, he went, had a lot of chest and abdominal symptoms, so went to see his private gastroenterologist. Endoscopy again was done. It showed Barrett still without dysplasia, and went back to the esomeprazole twice a day, as well added the famotidine, but was still symptomatic for GERD. Next slide. So the question is, what would we recommend for patient 2 at this time? And it's another poll question. A is to change to another PPI, lansoprazole or rabeprazole. B, yearly endoscopy. C, refer to another gastroenterologist. D, refer to the surgeon. Or E, all of the above. We'll take a few moments and place your answers. Okay, so let us see. In the poll, okay, the highest answer is 41% E, all of the above. Okay, yes, and let's see, what's the second was kind of referred to the surgeon. We think yes, that D, is what we recommended. I'll go over the different choices. So A, yes, we could change to a different PPI. Probably would not choose between those two that are listed, but would rather, as Dr. Udasin had mentioned, the dexlansoprazole, which has different mechanisms and usually lasts longer, as well, can be taken with or without a meal. The other PPIs would need to be taken on an empty stomach, half an hour before a meal. B choice, continue with yearly endoscopies. Recall for him, he had Barrett's esophagus, but without dysplasia. So the recommendation for that is 3 to 5 years. But, we defer to the gastroenterologist. For others, right, Barrett's with low-grade dysplasia, the recommendation usually is every 6 to 12 months. And then for those with high-grade dysplasia, every 3 months. For choice C, refer to another gastroenterologist. He's gone to 3 different gastroenterologists and not sure at this time a 4th one would be so helpful. Instead, we do think, right, and we recommended this for him, since he's not responding to medications, we would refer to the surgeon for evaluation. He tried multiple medical treatments and still very symptomatic. Okay, and so that's why we think it's D. He was actually recommended and he received the Nissen fundoplication, and also recall he had a hiatal hernia. The repair was done and his symptoms, much improved. Right, currently want to mention also, right, that he's retired and has less stress now, so also would be beneficial to his GERD symptoms. Next slide. As another patient who came to our program later, it was in 2019, also a law enforcement responder, and was age 45. Was still working despite having chronic pain, suffered from a motor vehicle accident previously, had GERD symptoms, rhinitis since 2002, and was kind of treating it, treating the symptoms, on their own, would take medications. From 2002 to 2018, would take calcium carbonate or Tums, and when severe, would take ranitidine. When the patient came to our office in 2019, we recommended change to the famotidine since ranitidine is no longer on the market. And then also, was following the diet to avoid different triggers, and the keto diet seemed to help. And also, we made recommendation to follow with a GI doctor, but with busy lifestyle, was still working. Patients didn't get to do that. And for the rhinitis, was treated with nasal spray and seemed to be stable. So the next appointment was in 2 years. Came back with more GERD symptoms. The famotidine at this time didn't seem to help, and was changed then to the PPI omeprazole. Was given a course, but then symptoms would return after the course was completed. And to go back, right, the rhinitis, the headaches, and now, from the chronic pain, the neck pain from the accident was worse. Also seemed to be a little anxious. And we found out, a little bit more. There was a lot of family and work stresses. And then also, she was ex-smoker, occasional alcohol use. And, what would we recommend? Next slide. So this is our poll question. What would we recommend for patient 3? A is refer to the GI doctor for the long-standing GERD symptoms. B, refer to ENT for ENT-related symptoms. C, refer to mental health evaluation for anxiety. D, recommend orthopedic follow-up to review and discuss pain management. Or E, all of the above. Let's take a few moments then for the voting. Okay, so let's see. Okay, great. 94% chose E, all of the above, which we also feel was the best answer. Let's go through the other options. A, yes, refer to the GI with long history of reflux, which our patient does have. We do recommend, and she had endoscopy that showed no Barrett's, thank goodness, no H. pylori, but had gastritis and esophagitis, and recommended to stay on the PPI therapy. Patient was also recommended to ENT to evaluate the nasal congestion, the headaches, and was given treatment. C, with the anxiety, yes, we refer to mental health. And during the therapy sessions, the evaluations, we found out more. She was feeling a lot of pressure, at home, at work, and also to be the strong person. Also interesting, and she was not the first person to say this. She didn't think that her wine consumption, counted towards the alcohol. And with therapy, which helped, eventually a patient was able, to cut down and eventually eliminate intake. And she found that definitely helped her GERD. She was able to change to as needed PPI therapy. And D, for the last choice, yes, should also refer to the orthopedic provider to help with their pain management. Of note, she was on meloxicam, which can aggravate GERD to a lesser extent than the other NSAIDs like ibuprofen and naproxen. So therefore, E is the answer. Next slide. This is patient 4 who presented to the responder clinic as a firefighter at age 40 in 2016. Had GERD, asthma, sinus symptoms, which began in 2005. And, for the next decade, took treatments for the GERD, took antacids, and then was changed to omeprazole. For the asthma, saw his primary care and was on albuterol as needed. And for the sinuses, kind of just lived with it. So, when the responder came to our program in 2016, recommended to follow up with GI, and endoscopy was done, which showed gastritis, esophagitis, but no H. pylori, no Barrett's. And omeprazole was increased first once a day, then to twice a day. And then for the sinuses and the asthma, treatment was provided. In 2017, the next year, the GERD was severe, so followed up with the private GI. And, stayed on, the omeprazole was changed to pantoprazole. And then follow that up in 2018, the acid reflux was still severe on the twice-a-day pantoprazole. Got a referral to the World Trade Center program GI doctor. Endoscopy was done again, and then that showed hiatal hernia and Hill grade 1 to 2, and was recommended the TIF procedure. Next slide. I just put some pictures here. Hiatal hernias, can be described a few ways. One grading system is the Hill system, which looks at the gastroesophageal junction and how the closure of the flap around the endoscope. For grade 1 is snug, but as the higher grades, it gets looser and looser, with grade 4 being open, so there's no closure, and the acid from the stomach enters into the esophagus, irritating the esophagus. Another way, which is the second picture, is to describe it with relation to the position of the gastroesophageal junction, the stomach, and other organs in the abdomen. For type 1, which is the most common, the junction, moves or slides. It's about 95% the most common one. And so that junction slides, into the chest above the diaphragm. And then for the other grades, the type 2, the stomach, the other parts, not the junction part, moves into the chest, through the diaphragm. And 3 is mixed. It's both the junction and the parts of the stomach moving, into the chest. And then type 4, which is not common, it's rare, but another organ in the abdomen moves into the chest. And then to go on with his history, okay, he underwent the procedure, the TIF procedure, and symptoms improved. He was able to taper down the PPI to as needed use. And then, for the next few years, 2020 to 2023, he had rare symptoms. But then, again, this year, started to have some belching, and then a chest discomfort. He was on, he went back to taking the pantoprazole, and then, got scared, right, especially with chest discomfort. He went to the ER 3 times. Next slide. So the poll question is, what is happening and what would we recommend? Choice A is a cardiac reason and recommend cardiac testing. B is acid reflux and would recommend GI for repeat endoscopy and other tests. C is acid reflux and surgical referral for possible intervention surgically. Or D, all of the above. Let's take a few moments and answer your answers. Okay, so let's see. Okay, so I see, right? Majority did pick D, excuse me, all of the above. There's some, cardiac testing and GI follow-up. We did recommend D, all of the above. So let me go through the options. A, is it cardiac related? Possibly. Usually in the ER, they would check, make sure that MI, myocardial infarction, was ruled out. But it's reasonable. He's in his 40s, later 40s. And to refer to the cardiologist to rule out, which he had done, and they were okay. The cardiologist told him it was a non-cardiac etiology. B, referred to the GI doctor. And, some thoughts, belching may be due to the valve wrap from the TIF being too tight, but the heartburn symptoms suggest loosening or the hiatal hernia. And then the next option, surgery. Yes, yeah. To go back, usually TIF procedures last about 8 to 10 years, which is similar to the surgical one. Our patient was only about 5 years, but then, when symptoms return, and we need treatments, which he's on, the PPIs. The GI doctor recommended surgery evaluation, which he had. Surgery wanted a few procedures before, the esophagram, to take a look at the stomach, at the esophagus. And then also, manometry to look at the pressures and the function of the esophagus, and was recommended fundoplication. So the answer is D. He's still thinking about that and, hasn't made a decision yet. Okay. Thank you very much for participating in the poll questions.
All right. Thank you, Dr. Udasin and Dr. Lin, for a very excellent and interesting presentation. So we're getting close to the end, and so I will discuss how to get your continuing education credits. So again, this can be a little complicated, so I recommend doing a print screen here so you have this information. So to get the CE credits, you're going to need to log into the CDC Train system. You can just either Google CDC Train, or I've got the website here. Then you'll need to find the course. The simplest way would be for this live course is just to type in the WC 4740. And then this course should pop up. You might also see the previous course that we did on PTSD and anxiety. And if you want just this course, you would also include that date, 10/24/24. Then it'll ask you for an access code, which is the World Trade Center Health Program initials there. And if you're watching the recording, the way you find this course is by searching for WD 4740. And for the folks viewing the recording, there is no course access code. So then you'll be asked to indicate what type of CE credits you want. Then you've completed the course. You'll mark it as completed, which will then take you to the post-test. You'll have 2 attempts to pass it, and then you'll be asked to complete the evaluation. And then finally, if you've passed the test and you've completed the evaluation, you'll get a link to the certificate that will provide evidence for your continuing education credits. So you can get the CE credits for the next 30 days. Then after 30 days, you'll need to get the credits for the recording, so the web on demand. And then just an announcement for our next webinar, which will take place on December 12th. It'll be on substance use and related disorders in trauma-exposed populations, essentials for screening and intervention. And that webinar will be presented by Dr. Lowe from Mount Sinai and Dr. Dowling from the Stony Brook School of Medicine. So hopefully you can attend that lecture. It'll also be for 1 hour, and we'll be offering CE credits for that. And so with that, thank you for attending today, and we look forward to see you in about 3 weeks, I think, or actually not 3 weeks. It'll be about six or 7 weeks. So hopefully you can join. And again, thank you to our speakers. Thanks to our technical staff, Ann Riddle and Kiana Harper. And have a great rest of your day. Bye.